Primary biliary cholangitis (PBC) is an autoimmune disease condition. Look at this picture, shows that liver, gallbladder, and destruction of small intrahepatic bile ducts. Look at this. Then CT scan findings and MRI findings. Look at this. A detail going on. Introduction. Primary biliary cholangitis is a chronic progressive autoimmune liver disease that mainly affects middle-aged women. It results in the gradual destruction of the small intrahepatic bile ducts, leading to bile accumulation, inflammation, fibrosis, and eventually cirrhosis. Previously known as primary biliary cholangitis, the disease was renamed to better reflect its nature and early stage diagnosis. Definition. Primary biliary cholangitis is a chronic autoimmune disease characterized by immune mediated destruction of the small intrahepatic bile ducts, leading to cholestasis, liver inflammation, fibrosis, and eventually cirrhosis, and liver failure if untreated. Etymology. The term primary biliary cholangitis is derived from Latin and Greek roots. Primary meaning the initial or main condition, biliary. From Latin, bilis meaning bile, and cholangitis from Greek, choli bile, and angiitis inflammation of vessels or ducts. Together it refers to a primary inflammatory disease of the bile ducts within the liver. Primary biliary cholangitis predominantly affects middle-aged women with female to male ratio of about 9:1. The global prevalence varies ranging from 1 in 1000 to 1 in 3000 women over 40 years and is more common in North America and Northern Europe. Types. PBC is not classically divided into subtypes, but it can be staged based on Histological findings. 1. Stage 1, florid duct lesion, portal inflammation and bile duct injury. 2. Stage 2, ductular proliferation, periporotal extension and fibrosis. 3. Stage 3, septal fibrosis, bridging fibrosis between portal tracts. 4. Stage 4, cirrhosis, nodular liver transformation and end stage liver disease. Causes. The exact cause is unknown but is believed to involve genetic predisposition and environmental triggers that stimulate an autoimmune response. Possible causes: 1. Autoimmune attack against biliary epithelial cells. 2. Genetic factors, example HLA DR8 allele. 3. Environmental triggers, infection, smoking, xenobiotics. 4. Molecular mimicry, foreign antigens resemble self antigens. Risk factors: 1. Gender, women 90% of cases. 2. Age, 30 to 60 years. 3. Family history of autoimmune diseases. 4. Other autoimmune conditions, example Sjogren syndrome, rheumatoid arthritis, autoimmune thyroid disease. 5. Smoking. 6. Urinary tract infections or exposure to certain chemicals. Complications: 1. Cirrhosis. 2. Portal hypertension. 3. Esophageal varices. 4. Ascites. 5. Hepatocellular carcinoma. 6. Malabsorption of fat soluble vitamins A, D, E, K. 7. Osteoporosis. 8. Hyperlipidemia. 9. Proteus related skin damage. 10. Fatigue and depression. Pathophysiology. Pathophysiology of primary biliary cholangitis, step by step process. 1. Autoimmune trigger. A genetically predisposed individual is exposed to environmental triggers, example infections, chemicals that cause an abnormal immune response. 2. Activation of the immune system. The immune system, particularly CD4 and CD8 plus T cells become activated and mistakenly recognize mitochondrial antigens, especially the E2 components of pyruvate dehydrogenases complex PDC-E2 in bile duct epithelial cells as foreign. Three, destruction of intrahepatic bile ducts. Immune mediated attack leads to chronic inflammation and gradual destruction of the small intrahepatic bile ducts, impairing bile flow. 4. Cholestasis, bile stasis. As bile ducts are destroyed, bile accumulates in the liver, which means cholestasis, leading to toxic injury of hepatocytes due to retained bile acids. 5. Inflammation and fibrosis. Persistent bile duct injury causes portal inflammation and triggers fibrosis, scarring in surrounding liver tissue. 6. Progressive fibrosis to cirrhosis. Continued fibrosis bridges portal tracts and eventually disturbs liver architecture, leading to nodular regeneration and cirrhosis, end stage liver disease. 7. Complications. Cirrhosis results in portal hypertension, liver failure, and increased risk of hepatocellular carcinoma. Signs and symptoms. 1. Fatigue. 2. Pruritus, itching often at night. 3. Dry eyes and mouth. 4. Right upper quadrant discomfort. Later symptoms. 1. Jaundice. 2. Hepatomegaly. 3. Hyperpigmentation. 4. Exanthemas and exanthemas. 5. Ascites. 6. Bleeding tendency. 7. Splenomegaly. 8. Weight loss. A diagnosis. 1. Blood test elevated alkaline phosphates ALP and JAM glutamine transfers GGT. Positive anti mitochondrial antibody AMA presents in 95% of cases. Elevated IgM levels. 2. Liver function test. 3. Imaging, ultrasound, CT or MRI to rule out obstruction. 4. Liver biopsy confirms staging and rules out other diseases. 5. Transient elastography measures liver stiffness. Nursing diagnosis. 1. Fatigue related to chronic disease process. 2. Impaired skin integrity related to Reuters. 3. Imbalance nutrition less than body requirements related to malabsorption. 4. Risk for bleeding related to vitamin K deficiency and liver dysfunction. 5. Anxiety related to chronic illness diagnosis and prognosis. Medical management. 1. Ursodeoxycholic acid UDC first line treatment to improve liver function. 2. Obesiticholic acid for UDCA non-responders as therapy combination. 3. Antihistamines are to relieve pruritus. 4. Vitamin supplements A, D, E, K, F malabsorption present. 5. Bisphosphonates for osteoporosis. 6. Liver transplantation in cases of liver failure. Nursing management. 1. Monitor liver function test and symptom progression. 2. Encourage a well balanced low fat diet. 3. Provide skin care and monitor for signs of infection or breakdown. 4. Assist with fatigue management, example pacing activities. 5. Provide emotional support and education. 6. Ensure compliance with medication and follow-up visits. Treatment options. A. Pharmacological. 1. Ursodeoxycholic acid. 2. Obeticholic acid. 3. Rifampicin for pruritus. 4. Antihistamines. 5. Immunosuppressive therapy in trials. B. Non-pharmacological. 1. Nutritional support. 2. Exercise to reduce fatigue. 3. Pruritus management strategies. 4. Psychological counseling. C. Surgical liver transplantation for end stage disease. Psychosocial medicine. 1. Support groups. Joining PBC specific patient groups for sharing experiences and emotional support. 2. Cognitive behavioral therapy CBT to address anxiety, depression, or adjustment disorders related to chronic illness. 3. Stress reduction techniques, mindfulness, meditation, and relaxation techniques to reduce stress related symptom exacerbation. 4. Patient education, providing knowledge about disease, progression, medication adherence, and symptom management. 5. Social work support, assistance with financial issues, work adjustment, and disability support. Prevention. There is no known way to prevent BBC, but early detection and treatment can delay progression. Preventive strategies focus on 1. Regular monitoring of liver function. 2. Early treatment with UDCA. 3. Avoiding alcohol and hepatotoxic drugs. 4. Managing associated autoimmune disorders. 5. Healthy lifestyle choices, example, no smoking, balanced diet. In conclusion, primary biliary cholangitis is a slowly progressive autoimmune liver disease. Predominantly affects middle-aged women. Although the disease can lead to severe complications like cirrhosis and liver failure, early diagnosis and treatment, particularly with ursodeoxycholic acid, can significantly slow disease progression and improve quality of life. Multidisciplinary management involving hepatologists, nurses, dietitians, and mental health professionals is essential for optimal patient outcomes. Thank you. Have a nice day.